You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 21st, 2025. This week, a big trial in cardiac pacing has finally been published. PVCs and cardiomyopathy, cannabis, cardiovascular risk, and the danger of observational studies, and finally, the tale of two disparate statin trials. First up is the BioPace Trial. The EuroPace Journal has published the results of the BioPace Trial, first presented at the 2014 ESC meeting in Barcelona. The trial compared BiV pacing versus standard RV pacing in patients who had bradycardia and who would require lots of RV pacing. BioPace was basically a preventive trial, the idea being that standard RV pacing does fix the bradycardia, yes, but RV-paced beats create dysynchrony, much like a left bundle branch block, and that can induce pacing-induced left ventricular dysfunction in a certain but highly debated number of patients. But BiV pacing is harder. It requires a third CS-LV lead. The question BioPace trial tested is whether the preventive, more synchronous BiV pacing would lead to better outcomes than the old standby, the single RV pacing lead. It was a multi-center RCT conducted more than 20 years ago, first started randomizing patients in 2003. This was 1,800 patients that randomized to either of the two pacing strategies. The primary endpoint were two, death or heart failure hospitalization, and second co-primary survival time. These patients were typical bradycardia pacing patients in their 70s, about 90% RV pacing at 1 month, so they did pace a lot. The mean ejection fraction, importantly, was normal at 55%, but nearly 10% had an ejection fraction less than 35%, and about a quarter had EFs between 35 and 50%. Listen later, and I'll give you the EF subgroup analysis of BioPace, and remember here that the positive for BiV pacing block HF trial included patients with an EF less than 50%. So all patients in block EF, which was positive, had impaired LV function. So the results of BioPace, over a mean follow-up of nearly 6 years, so a good follow-up, a primary outcome of death or hospitalization for heart failure occurred in 38.4% in the BiV arm and 40% of the RV pacing arm. That hazard ratio was 0.78, but the confidence intervals went from 0.76 to 1.02, and the p-value was 0.09, and so this was a non-significant finding. The second co-primary endpoint of survival was also not different, with both groups having a death rate of 33.8%. Now, trials like this have lots of crossovers, and the authors provided an as-treated analysis, which also showed no significant differences. Now, you might wonder if the patients in BioPace who had lower EF, like those in block HF, did better with BiV pacing. Nope. Subgroup analysis showed no heterogeneity of treatment effect for any endpoint. Now, for the secondary endpoints, there was also no difference in 6-minute walk test nor quality of life questionnaires. There were, however, more adverse events in the BiV pacing arm, 115 versus 72 procedure-related adverse events and 87 versus 54 lead-related adverse events noted in the BiV versus RV group, and that's obviously everybody would understand why that is, because BiV pacing is more complicated. The authors concluded, rightly I think, that, quote, in patients with preserved EF who require pacing and will pace in the RV, BiV pacing did not prove superior and was associated with numerically more adverse events. The authors also add that RV pacing may be less harmful for this type of patient than previously thought. Now my comments. What a nice trial this is. I love it. It directly challenges my beliefs. I am an enthusiastic believer in synchronous RV pacing. Now, while it is older data with BiV pacing, the publication comes at a crucial time for our field of EP. Now, why do I say that? Because the hottest topic in all of EP right now is conduction system pacing, wherein we can achieve ventricular pacing with synchrony of RV and LV by placing the ventricular pacing lead at either the His bundle or the left bundle in the septum. Essentially, what we have learned with conduction system pacing is that it can do CRT with one lead instead of the two required for BiV pacing in the RV and LV. Now, I and a huge number of my colleagues feel that pacing the conduction system will prevent pacing-induced cardiomyopathy. I and many of my colleagues, therefore, do conduction system pacing routine as first line. But, BioPace should cause us proponents to reconsider these two prevailing ideas. One is that RV pacing is terrible. Second, that more complicated pacing is better than simple RV pacing. Now, on the matter of pacing-induced cardiomyopathy, observational studies put this incidence in the range of 10 to 20%. And we know for sure from the early ICD trials that had pre-existing heart failure, RV pacing was bad. More RV pacing meant more heart failure outcomes. But that's the thing. BioPace enrolled the more common patient, the one who presents with heart block or combined sinus node dysfunction and heart block, the patient who has a preserved LV function and is going to pace a lot in the RV. They don't have significant heart disease, or at least they have minimal heart muscle disease. And in BioPace, the authors found very little harm from RV pacing. Heart failure events leading to death or hospitalization were not different in the two groups, and I inspected the Kaplan-Meier curves, and heart failure events occurred in less than 10% of either group over the first 3 years. That's a low rate of outcomes. So if you're a neutral observer, if you're not affected by the beauty of the narrow QRS from CS pacing, or the satisfaction of finding that perfect CS branch where the lead slides in, if you don't have all of this beautiful feedback, and you just look at BioPace as a person looking at data, you would strongly argue for sticking with standard RV pacing, less adverse events and no difference in outcomes. The neutral observer would say, look, you all have 700 primary outcome events in this trial. You have long follow-up. You have patients that we see every day, so there's good generalizability, and yet there's no benefit. This was not an underpowered trial, and I would have trouble refuting that. Except, I think there are some limitations and caveats. First, BioPace recruited patients in 2003. I was young then. You were young then. Many of the This Week in Cardiology listeners may have been children or teenagers then. This is an important point because BiV pacing has iterated quite a bit. LV leads and delivery systems, as well as our knowledge of where to put the lead, have improved a bunch. In BioPace, LV lead implants failed in 13%, and I suspect that's lower now. Another criticism of BioPace that I saw online was that death should not have been an endpoint because these patients were too healthy. And I think there's some merit to that criticism. The more typical heart failure endpoint of cardiovascular death or hospitalization for heart failure would have probably been better. Or even better than that would be total hospitalizations, because total hospitalizations would capture the adverse events. But on the other hand, death is the least biased of all endpoints. I would also argue that conduction system pacing, CSP, is likely going to be better than BiV pacing in both safety and efficacy. Safety with conduction system pacing is likely better because we're using one lead in the RV septum versus cannulation of the CS, venography, and CS lead placement. And smaller studies and observational studies suggest, albeit weakly, that the hemodynamics of CSP is better than BiV. But I want to emphasize the empirical support for this contention is weak. Now, BioPace should, though, infuse us CSP evangelists like me with a big bolus of humility. The standard RV pacing is not dead yet, and surely we should have more data with conduction system pacing. Now a couple comments on medical evidence. I worry that the 11-year delay in publishing this study had something to do with the negative results. BioPace was indeed an industry-supported trial. And at the time, 2014, when this was presented, BiV pacing was hot. It was sexy, the devices were more profitable, and you might say, Mandrola, that's cynical thinking, don't even go there. Well, let me ask you about the counterfactual here. Had the BioPace trial been a huge win for IV pacing, do you think the funders of the trial would have let it sit unpublished for 11 years? No, double no. So I really worry about this delay in publication and what it says about how we think about medical evidence about positive trials and negative trials. The second topic today is another belief is going to be challenged in EP, and this is the notion of PVCs and cardiomyopathy. In my opinion, one of the most misunderstood and overtreated conditions in cardiology today are PVCs. And overtreatment of PVCs can get into hazardous areas quite quickly because ablation of PVCs can bring doctors to scary areas of the heart like the LV outflow tract, the thin-walled RV, and perihyscian areas, for instance. A recent paper from the University of Colorado group provided strong findings about another strong belief in EP, that is, if patients reach a threshold PVC burden, then they will develop cardiomyopathy and heart failure. The number in our town and in many towns is 20% PVC burden, but in other places PVC burden can be as low as 10% and be thought to cause cardiomyopathy. And observational studies vary considerably in the predictors of cardiomyopathy. Jack featured a state-of-the-art review paper last year, and I'll link to it. In one paragraph on predictors of PVCs and cardiomyopathy, they had over 40 references looking at things like PVC burden, coupling interval, variability of coupling interval, the QRS width of the PVC, whether it's epicardial origin, and many more. Now, another issue with this whole matter is I do not trust echo reading in the presence of PVCs. I'm sorry. I'm not an echo expert, but I trained in Indiana with Feigenbaum, and I can just tell you in the era of digital echo reading, if an apical 4-chamber includes a PVC, I don't know that the EF is accurately estimated. It's often underestimated. The University of Colorado group now adds to the melee of observational studies. They analyzed more than 30,000 ambulatory monitors on patients between 2017 and 2023. They included only those who had a PVC burden more than 5% and more than 24 hours of monitoring. And that latter point about the duration of monitoring is important, as just one day of monitoring can misrepresent, often underestimate, the degree of PVC burden. They also searched for people who had a transthoracic echo done within 3 months of the monitor. They defined a cardiomyopathy as any EF less than 50%. They found a total of about 1,400 patients who fulfilled those criteria. The average age, 68, 40% female, and the average PVC burden was 12%. Of the 740 patients who had a transthoracic echo, the mean EF was normal at 55%, with 22%, or 1 in 5 patients, having an EF less than 50%. Here's the key finding. In both unadjusted and adjusted analysis, they found no significant association between PVCs and LVEF, nor with PVC burden and depressed LV function. None. The conventional 20% cutoff of PVC burden showed no predictive value, and no trends were seen linking increasing PVC burden or prolonged PVC exposure to reduced ventricular function, and they concluded that in this sample, PVC burden alone was not an independent predictor of cardiomyopathy. My comments. I include the single-center observational study, even though there have been many similar studies in this space, because it is A, recent, and B, it challenges the prevailing therapeutic fashion that PVC burden more than 20% should trigger treatment, such as ablation. It's an important observation in this paper because treatment decisions for PVCs is one of the hardest areas of EP. And this can never be made into an algorithmic decision. For instance, I have seen oodles of patients with more than 20% PVC burden who have no symptoms, no heart failure, and no LV dysfunction. Yet, I have also seen some of these asymptomatic PVC patients made sick by their doctor's words. Once happy and living life, the patient with asymptomatic PVCs comes to the EP consult fearful and addicted to their cardio device because the doctor scared the patient. Now, I've also seen patients with very low PVC burdens who are terribly symptomatic, and counseling and reassurance do not work. So please, friends, be careful with your words when counseling patients with PVCs. Be cautious in the use of PVC burden cutoffs. Now, I do recommend this paper Take a look at it, as well as the excellent state-of-the-art review that I cited earlier. And perhaps the most important sentence from that state-of-the-art review, which is first author Puri Sureshi. Now, here it is, quote, in a prospective cohort study from 2012 to 2017, 100 asymptomatic or minimally symptomatic patients with frequent idiopathic PVCs, of that group, 44%, nearly half, experienced a decrease to 1% PVCs without ablation and without antiarrhythmic drug therapy. And this finding highlights the high rate of spontaneous PVC resolution. So yes, as it is with atrial fib, with PVCs, I also say, give peace a chance. There is very often spontaneous resolution of PVCs. Nothing in medicine could be more elegant than resisting the urge to intervene and let nature cure the problem. While I do PVC ablation, I try first to make sure the PVCs will not disappear on their own. I also try big doses of reassurance and education. Ablating PVCs can become harrowing. Be careful out there. Do not be influenced by EP Twitter either, because on EP Twitter, no one puts their 6-hour cases that fail or cause tamponade or heart block or stroke or aortic damage. All right, third topic today is cannabis and cardiovascular risk. Jack Advances has published a brief report that hit the social media jackpot. The question was to assess the long-term cardiovascular risk of cannabis. The authors used a data source called TriNetX, which is drawn from 53 healthcare organizations. The study population included adults younger than 50 years. The time course of the study was 8 years between 2010 and 2018. Now, the comparison group, which they got by ICD codes, were simply cannabis users versus non-cannabis users. Now, this included patients who were free of comorbid conditions such as MI or heart disease or diabetes or hypertension or tobacco use, so the relatively good health of these patients was planned and intentional. This was a huge database study of more than 4.6 million adults. About 2%, so 93,000, were cannabis users, and 4.5 million were not. So you have a study comparing 2% of the sample to 98% of the sample. So already, come on, that's going to be difficult. Of course, the authors attempt matching. Here they use propensity scoring. The key findings over 5 years, MI absolute risk was 0.55% versus 0.09%. That's a relative risk of like 6x higher in cannabis users, but the absolute risk difference is only 0.45%. So if we were just doing number needed to harm, that's in the range of 220. There were similar findings for ischemic stroke. There was a big relative risk difference of 5x higher for cannabis users, but a tiny absolute risk difference of only 0.3%. Same with MACE. For AFib, the relative increase was only 2x higher, and the absolute risk increase was in the range of 0.43%. For all-cause mortality, the relative risk was only 1.5 times higher, with an absolute risk difference of 0.45%. So the authors concluded that this data links cannabis use to adverse cardiovascular events. Notably, this was a population without comorbid conditions and relatively young age. But the last line of the paper uses causal words. Quote, in conclusion, the findings underscore significant cardiovascular risks associated with cannabis use, reinforcing the need for public health initiatives and heightened clinician awareness. Note the words underscore and reinforcing the need for health initiatives. These are definitely causal language. Now, my comments. I don't love cannabis, but I also don't love the conclusions of this paper. It's fine to make associations in epidemiologic studies, but recall how Bradford Hill established the cause-effect of smoking in heart disease and cancer. Epidemiologic studies such as this one were only one component of causation, but Hill also had biologic mechanisms, which are clear for tobacco, right? It's a carcinogen, it causes endothelial dysfunction. Bradford Hill also had natural experiments wherein countries and regions that started smoking bans also saw less heart attacks. And Hill and colleagues had consistency and specificity, meaning that the smoking link holds up in different populations in different time periods. They also had a clear dose-response curve with smoking. This week's study are but one of the components of showing a causal connection, and that is the epidemiologic association. These types of studies are perhaps the weakest component of causal inference. Let's review the three main issues with these non-random look-back comparison studies, these observational studies. First in this paper is selection bias. Simply, do cannabis users have higher rates of MACE because of the cannabis or because of other factors, such as the ones that perhaps induce cannabis use, things like insomnia, mental stress, etc.? Now, the authors might say they corrected for baseline factors, but you know that adjustment only corrects for those factors that are in a database. The second issue with papers like this is the matter of Dara Zaratker's work on specification curve analysis, where the McMaster's team shows that observational studies like this have many thousand different analytic choices when looking at data from 5 million patients, and how one chooses their analytic method can affect outcomes. A good example, for instance, I remember the 2018 HRS meeting where a Colorado group showed in MI patients that cannabis users versus non-users had a lower in-hospital mortality. That study is published in PLOS One now, and I'll cite it. The third issue with studies like this is this chart review using codes. There is no data on dose response, for instance, and you would really want to see a dose response if you plan to infer causation of cannabis use in cardiovascular events. So, in sum, please be sure. I think the likelihood that cannabis use is protective is super low. In fact, I suspect that recreational use of cannabis likely leads to bad health. While studies like this garner tons of attention, they are nowhere near robust enough to infer a causal link. To me, the most useful aspect of these types of studies is in teaching critical appraisal. And my final comment here is, while I don't think cannabis will likely pan out as a useful therapeutic, the fact that it has been illegal has precluded its use in proper RCTs, and I would not be surprised if a proper RCT in a very selected cohort found that cannabis could have some short-term benefit in, say, something like chemo-induced nausea or anorexia or pain relief or headaches or something like that. All right, final topic today concerns cardio-oncology. The journal, JACC Cardio-oncology, has published a pre-specified sub-analysis of the STOP-CA trial of statins to prevent cardiotoxicity from anthracyclines. It's an important topic because up to 20% of patients who get anthracycline can develop heart failure at 5 years. Now, recall that that JAMA published the STOP-CA trial in 2023. This is a highly positive trial that was controversial, at least to me. One reason for curiosity of STOP-CA was that before even looking at trial procedures, etc., there was a Wake Forest-led RCT called PREVENT of statins for prevention of LV dysfunction in anthracyclines, which failed to show a benefit. And PREVENT was published a year before in New England Journal of Medicine. Now, STOP-CA had 300 patients with lymphoma who had anthracycline-based chemo, and they received either 40 of atorvastatin or placebo for 12 months. The primary outcome of the proportion of patients experienced a decline in left ventricular ejection fraction of greater than 10% from baseline to a final value of less than 55% over a year was significantly lower in the atorvastatin group, 9% compared to placebo, 22%, a highly significant p-value. And in subgroups, atorvastatin showed greater benefit in patients who were older than the median age, or those patients who had a higher anthracycline dose, or obese patients and females. Now, I remember I was there when it was presented. There was great celebration about this. But there were problems. There was missing data where not all subjects had MRI at baseline and follow-up. And of course, change in ejection fraction is very much a surrogate outcome, which I previously mentioned is highly imprecise. What's more, how exactly does a statin exert such a great effect in 12 months? It would seem like longer timeframes would be needed. Now, this sub-study in JACC Oncology took a subset of patients in STOP-CA, and they looked at before and after MRI scans. Now, they chose another highly surrogate marker. This was a greater than 3% increase in extracellular volume on MRI. And I'm not an imager, so I'm out on a limb, but they chose this because it is a marker of interstitial fibrosis. In other words, it's a surrogate of a surrogate. And interstitial fibrosis is a purported mechanism of anthracycline-induced toxicity. Now, the cutoff value was chosen based on its association with heart failure and cardiovascular death in cancer patients treated previously with anthracyclines. Now, indeed, this sub-analysis was quite positive. Atorvastatin significantly reduced the likelihood of experiencing elevated extracellular volume. Specifically, the odds of the elevated extracellular volume were 80% lower in the atorvastatin group compared with the placebo group, odds ratio 0.20 and a highly significant p-value. Although 29% of the patients in the placebo group showed an elevated ECV, only 8% of those receiving atorvastatin had exhibited this increase. Furthermore, a 3% increase in extracellular volume was linked to an absolute decline of 8 percentage points in LVEF. And there was also a trend, albeit with small numbers of patients, to suggest that if you had extracellular volume expansion, heart failure events were 24% versus 8% compared to those without the 3% ECV expansion. The authors suggest that they have found a mechanistic explanation for the benefits in statin therapy in the main STOP-CA trial. My comments. I really like the editorial from Dr. Giselle Melendez and Angelica Rojas. They write, quote, "There is no doubt that further studies are needed to address unresolved questions before statins can be widely recommended for the prevention of cancer therapy-related cardiovascular toxicity. Quote, it remains to be determined whether the expansion of ECV can predict the long-term development of heart failure, and more importantly, whether statin-mediated prevention of cardiac fibrosis can halt the progression of LV dysfunction." And I just want to celebrate these editorialists. It's just excellent. To me, an outside observer in this field, I would say you have one negative trial, PREVENT, one positive trial, STOP-CA. Just do a third trial with more patients and longer follow-up. NIH should clearly fund such an important trial. And in this trial should have a clinical endpoint. And it should have EF as a secondary endpoint. I worry about surrogate measures and mechanistic studies. These things are fine for forming hypotheses. But the ultimate thing that a practicing doctor needs are trials with clinical outcomes, properly powered trials. Okay, that's it for this week in cardiology, but next week I will see my colleagues in Vienna for the European Heart Rhythm Association, and I'll also have a preview next week of the big ACC meeting, and I'll be covering ACC as well. And gosh, we have to figure out a way to separate these two important meetings. I urge the leadership of European Heart Rhythm and ACC to get together and let's get these meetings separated so we can be able to go to both of them. So that's it for this week in cardiology. As always, remember, if you like this podcast, take the time, give the podcast a rating, write us a review. If you don't agree with something I said, send me a note. I always learn from these comments. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.